Good evening, everyone. I hope I'm audible. All right. Uh, I'm Dr. Midhun Mohan, faculty in emergency medicine and critical care from Doc Tutorials. I did my MD, I did my MBBS as well as MD in emergency medicine from Kozhikode District Cooperative Hospital. It is the largest hospital in Asia. And after that, I did my DNB as well as got the Royal College degree in emergency medicine. Now I'm currently working as a senior consultant and heading the Department of Emergency Medicine at Kozhikode District Cooperative Hospitals. Till last couple of years, I have been working as assistant professor in emergency medicine at Calicut District, at Kozhikode Medical College itself. Then, over the last couple of years, I moved to Kozhikode District Cooperative Hospital. All right. So I'm very happy to be here because it's been such a long time since we have been getting requests from a lot of medicine residents. All right. We know very well that the NEET SS program has been a big success and he's running very well from the doc tutorial side. But most of these residents have been requesting us to start something like a residency app, okay, which will help them with to become a better clinician, okay, which will help them with the day-to-day management of cases. We know that a lot of residents, I myself am a PG teacher. I got residents, emergency medicine residents doing the residency program under me. So I know that we all know that there is a lacunae in the PG curriculum. Most of the hospitals may not be able to meet all the requirements to develop a full-fledged emergency physician or even a medicine resident. All right. So either there will be gaps here where the PG residents are very busy with the patients, they are not able to get the knowledge part, all right? Or there can be gaps in the skill part where there are not enough patients or the residents are not getting enough hands-on experience in many of the skills, all right? Just like knowledge, it is very important to have the essential skills, particularly emergency skills to manage your patients, right? Okay. There are basically three qualities which every clinician should be having: knowledge, skill, and virtue. Knowledge is knowing what to do next. Skill is knowing how to do it. And virtue is basically just doing it, right? It is the attitude or the confidence to perform when it is required, right? So knowledge, skill, as well as the attitude to perform, that comes with a lot of practice, right? A lot of learning. Okay. So NEET SS was essentially focused on how to improve your knowledge, but it was mainly from an MCQ perspective so that you can clear the NEET SS exam. But to make a better clinician, for you to become a better clinician, it's much more knowledge and much more practical information is required, right? So what Doc Tutorials, I'm really happy that Doc Tutorials is coming out with this PG curriculum or PG residency program app. All right. And all of us have been working tirelessly to make it as good as possible, as worth as possible for all the residents out there. Because we passed through this stage and we know what the residents require, all right, during the residency time. Okay. So we have been working tirelessly to make this product better and better, and the work is still on the go here. And the game-changing thing here is that we will be discussing, rather than having hours and hours of lecturing, we'll be discussing on real patients, about real patients. Okay, how we manage those patients and what are the better ways we could have done. Of course, everywhere there are going to be limitations. So what is the ideal thing which should have been done? And if it's not available, what else can we do based on our resource constraint settings? All those kind of practical things we'll be discussing. All right. And from emergency and critical care perspective, okay, this is one of the toughest areas to get the hands on. And unless you are prepared, you won't be able to save the life, okay, when it is required. All right. And to teach emergency cases, it's really challenging. It was really challenging. All right. But luckily, uh, I have this collection which of lot of patient information, um, especially for teaching my own residents. Of course, all these cases have been obtained. All the information from the patients, the patient videos we have, patient pictures we have, the investigation reports we have, all these have been obtained after getting the consent for educational purposes. All right. So I'll be sharing all those things with you. All right. As we launch the app. All right. Then another important thing is we are introducing something called as skill-based learning. Okay. We have the case-based learning section. And apart from that, we have something called as a skill-based learning section. Okay. Now, there is a lot of encouragement for using simulation-based learning, right, on high-fidelity mannequins. And doc tutorials, we have procured a lot of high-fidelity mannequins, which it's very hard to differentiate these mannequins sometimes from real patients. Okay, many of these mannequins can have signs as well as uh, clinical features which you can have in real patients. All right. And what we are trying to do is that, see, on mannequins we can make mistakes, right, so that we don't make any mistakes on our patients. Okay, so we learn on mannequins, so I will be demonstrating a lot of things on these high fidelity mannequins, how things should be done, how the skills should be performed on mannequins, so that you can impart the same on real patients without causing much harm or without causing any harm to these patients. Okay. And if you are prepared, Doc Tutorials is willing to conduct even live workshops, hands-on session on these high fidelity mannequins at your place. All right. Okay. So that's one area which, from my perspective, it's going to be a game changer in a residency curriculum. All right. Then this session on basics of mechanical ventilation, this is just a teaser before the launch of the big product. Okay. And we are going to have a series of faculty or series of speakers talking on some of the basic things which we need to know during our residency time. All right. And I'll be taking the basics of mechanical ventilation. This is going to be, uh, usually this is, I find many of the residents, I used to find mechanical ventilation a challenge during my residency time. And it took me years of practice, years of managing patients on mechanical ventilation, especially during the COVID time, to get my basic knowledge as well as the advanced skills in managing patients on mechanical ventilation. So this is a very important topic, but because of time limitation, I'll be touching some of the main important points, okay, which can help you to learn about this topic further. I'll be having a whole series of sessions on this, on real ventilators, bedside teaching on ventilators, real patients, as well as simulated patients. All right. Uh, and if you are interested, you can go through the app. In the residency app, I'll be doing a lot of videos on mechanical ventilation. So in this session, we are just going to stick on to the basics. All right. So it's not going to be a complete thing, but this is something on which you can build on. This is something just for you to start with. All right. Okay. So let's begin. All right. Okay. First of all, disclosing that I have obtained consent. All these patients have been taken care of by me and my team, and I have obtained written consents from the patients or their relatives to use these materials. I'll be demonstrating some of the patient videos, and only after obtaining consent for education purposes, I'll be disclosing that. All right. Okay. All right. Now, what made this mechanical ventilation thing or the topic of mechanical ventilation tough for me during my residency time was there was a lot of physics involved in it, right? Okay. there is a lot of pressures like plateau pressure, positive and expiratory pressure, driving pressure, and all these pressures are driving you crazy, right? Okay. Now, in addition to that, you need to learn a lot of mathematical equations, a lot of numbers you need to keep in mind. And finally, there is this thing, mechanical ventilator itself, which is a machine, right? So any machine, you need to have a deep knowledge on how to use that machine. All right. So if you don't know how to use the machine properly, instead of saving life, it can be actually causing more harm. Okay. So that was a concern for me. So today's topic, we are going to start with something called as respiratory mechanics, or the physics in our biology of breathing, or simply to put it, how do we normally breathe? All right, let's start with that. Okay. And after that, I'm going to take you to some ICU ventilators. We will be discussing the parts of the ventilator. And finally, we will touch on the different modes of ventilation. All right. So that's something which will help you to start a patient on the ventilator. All right, let's start. So how do we breathe? All right, we know this thing, right? We get respiratory trigger, neuronal trigger from the respiratory centers in the brainstem, and these travel down the neurons to reach our inspiratory muscles. It's as simple as that, right? So the neuronal triggers will trigger the inspiratory muscles. So which are the main inspiratory muscles? It's mainly the diaphragm, right? Diaphragm as well as the parasternal portion of intercostals. Just remember that. Okay. This is not something which we usually learn, but these are the muscles mainly involved in inspiration. Okay. Then you got accessory muscles, right? When you are trying to have forced inspiration to your inspirated capacity or vital capacity breaths, you got accessory muscles like sternocleidomastoid muscle, pre-intercostal muscles, then scalene muscles, which will help you with inspiration, right? Now, how do these muscles result in the intake of a breath? Okay. Now, what usually happens is that you can see that at the end of expiration, the rib cage is its in least volume state. Okay, it's sort of all the ribs are sort of crowded and it will be sort of in a slanting position like this. Okay, now what happens when the diaphragm as well as the parasternal intercostals contract is that the diaphragm sort of flattens out, right? Normally in the relaxed state, the diaphragm will be in a dome shaped, and when it flattens out, what happens is that it increases the craniocaudal diameter. It also increases the anteroposterior diameter as well as the transverse diameter in the lower part of the chest wall. All right. So the lower thoracic cage will increase in volume. Okay. Now, similarly, the parasternal intercostals will increase the diameters in the upper part of the rib cage. All right. So the whole rib cage will get elevated like a bucket handle, just like a bucket handle, and spacing between the ribs will get increased. There will be flaring out of the ribs. All right. So the whole thing is that there will be increase in the intrathoracic volume here. Right. Okay. Now, if you remember one basic principle in physics, whenever there is an increase in the volume in a closed cavity, the pressure, what happens to the pressure inside it? Whenever the volume increases, pressure will decrease. Right. Okay. Now, as the pressure decreases, okay, now the pressure is going to be lower pressure there compared to what? Compared to our atmospheric pressure, right? Now, the whole thoracic cavity as well as the lungs inside it is exposed to the atmosphere through our airways, right? Through our mouth as well as the nasal opening, it's exposed to the atmosphere, right? So whenever there is a lower pressure inside the thoracic cavity compared to the atmosphere, there is a pressure gradient created, right? Pressure gradient or a pressure difference created here, right? Now, another basic principle you need to remember is that air always flows from higher pressure to lower pressure, right? Till both the pressures become equal, right? Okay. So in this experiment, you can see two balloons are connected to each other and air is flowing from a balloon with higher volume and higher pressure to the other balloon. Okay, till the pressure in both the balloons become equal. But you can see the volumes in both the balloons are not equal because they are different balloons. They are not the same balloons. Okay, but the pressure inside them will be the same. All right. Till then, the gas will flow from higher pressure to lower pressure. You might have heard about cyclones and hurricanes, right? Okay, before that, all what happens is that there will be some kind of low pressure system forming in the oceans, and all the air will be drawn toward that side. From high pressure side, air will be flowing towards the low pressure side, which will result in the all these cyclones and hurricanes and all. The same principle goes here as well, right? Now, whenever we talk about atmospheric pressure, we know that the normal atmospheric pressure is around 1 atmos. It depends on it varies with the unit, right? Now it's around 760 millimeter of mercury, or you can say it's 1033 centimeter water or 101 kilopascal. But for ventilation purpose, we are considering the atmospheric pressure as our reference zero. Okay, you heard me right. It's not actually zero, but we are taking it as the reference zero. Okay. Now, during inspiration, as the diaphragm and the parasternals contract, when you are creating a lower pressure inside the thoracic cavity compared to the zero atmospheric pressure. Okay. So what is less than zero? It has to be negative, right? So this lower atmospheric pressure, so the lower thoracic pressure that has been created is called a negative pressure. All right. So how we normally breathe is by the mechanism of negative pressure ventilation. I hope that is clear, right? Okay. So what we are normally doing is negative pressure ventilation. Okay. Now the best way to learn about respiratory mechanics is going to be by using something called as the tube balloon model. All right, or the straw balloon model. I'm sure that all of us are still blowing balloons, right? Okay, it's as simple as learning mechanical ventilation is as simple as knowing the principle behind blowing of a balloon. Okay. All right. Now I'm going to replace that with a model here. This is the straw balloon model. Okay. Now this is exposed to the zero atmospheric pressure, right? Now, this balloon, as well as part of the airway, is going to be inside the thoracic cage, right? I am going to draw a box here which represents the thoracic cage. Okay, so whenever there is a negative pressure created, this negative pressure will get transmitted to the lung as well as the alveoli. So there will be a negative pressure created inside the alveoli also there, right? So the pressure gradient created from the atmosphere to the negative pressure inside the alveoli, which will result in a flow of air or a volume of gas will flow into the alveoli till both the pressures become equal. That is the same as zero. Right. Okay. Now I want you to take a note at these things here. Okay. Let me just minimize that. All right. I hope you are seeing the units which I have written on the corner side of the page here. All right. Now, in mechanical ventilation, you need to know these units. Okay, because you are going to find these in a lot of textbooks as well as on the ventilator. Okay, so don't get confused. The pressure in mechanical ventilator is always mentioned in centimeter water unit. Clear, right? Now, the volume, especially tidal volumes, all kinds of volumes are measured in, or they are mentioned in the unit of milliliters. Okay. Now, the flow is measured or represented in unit of liter per minute. Now, what do you mean by flow? Flow is nothing but volume divided by time. Okay. Suppose if 500 ml of volume, some 500 ml of gas has flowed or passed through a point over 5 seconds. What is the flow or what is the flow rate? That will be 500 divided by 5. That will be 100 ml per second. All right. Now, if you convert that into liter per minute, you just need to multiply it with 60. Okay. So 60 into 100, that will be 6 liter per minute. So that's how you calculate flow. Luckily, you don't need to calculate these things because it will already be there on the ventilator screen for you to just look into. All right. Okay. Now the time, of course, is going to be seconds. So remember the units here. Okay. Now, can I say that whatever negative pressure has been created by the work of the inspiratory muscles, right? So this negative pressure that we are creating, we'll be calling it by the term P mus or the P muscles. All right. So the work done by the inspiratory muscles will be reflected as the pressure created by the muscles there. We'll be calling it as P muscles. Okay. Now, this pressure is responsible for creating the pressure gradient so that a volume of air flows into the lungs over a period of time till the pressures become equal. Okay, remember these terms because mechanical ventilation is all about pressure, volume, flow, and time. Okay, so these are the important things, four important things which you need to know about. Okay, these are the variables which you need to know about. Right. Now, this is another model which is showing that, see, at the end of expiration, you see there is some air left inside these balloons here, right? Now the diaphragm is in the relaxed state. Now, to simulate inspiration, we just need to pull down this hook. Okay, so there will be a negative pressure created and a volume of air will reach into the lungs there, all right? So this is going to be our tidal volume, the normal breathing tidal volume. All right, okay. Now, what if I need a higher volume, higher tidal volume? Suppose I am exercising a lot, I need a lot of tidal volume. Okay, maybe up to my inspiratory capacity. Excess volume I require. All right. And for that, what do you have to do? You need to pull down the diaphragm even further, right? That means the diaphragm has to do more work. More work here of the diaphragm as well as the inspiratory muscles means you have to create more of pressure, more negative pressure, so that more volume comes into the lungs. Just remember this, more pressure you generate, more volume is required, or more volume you will be getting. All right, okay. All right. Now, how much is this PMUS? How much work should the diaphragm as well as the inspiratory muscles do? And how much pressure should these muscles generate so that a volume of air or the tidal volume of air reaches our alveoli? For that, the first and foremost thing to know is that whenever a fluid flows or passes through a tube, there will be resistance in it. Okay. So the pressure between both ends of the tube has to be able to, should be able to overcome the resistance of the tube. Okay. So let's call it as the pressure needed to overcome the resistance or P resistance. All right. Now, I already told you that the alveoli or the lung is just like a balloon. It's an elastic structure. There is a lot of elastic fibers in our alveoli, right? Now, what is elastance or elasticity? Unlike the belief that elasticity means something that can be stretched, it's actually the exact opposite of that. If you remember the physics which we learned in high school and all, elasticity is the property of the substance which actually prevents the change in its shape or its volume, right? It's actually the exact opposite of distensibility. Okay. So in order to get air inside the alveoli and to distend the alveoli for gas exchange to happen, we need to overcome the normal elasticity or the elastic force of the alveoli. All right. So let's call it as the pressure needed to overcome the elastance or P elastance. All right. So the total work or the total pressure that has to be generated by the inspiratory muscles must be equal to pressure needed to overcome P resistance as well as pressure needed to overcome the P elastance. This is something called as the equation of motion of the respiratory system. All right, this is very simple, right? Okay, just keep this in mind because one of the commonest alarms that you are going to get whenever there is a patient on ventilator is going to be a high pressure alarm. All right. And you need to figure it out whether it's due to an increase in the P resistance or whether it is due to an increase in your P elastance, because then only you can do different treatment maneuvers that can reduce or overcome the problem here in order to reduce the total pressure. Okay. Otherwise, it's going to result in barotrauma, right? A lot of injury can happen. All right. So that's the importance of knowing these all pressures. Okay. Now, what is this pressure needed to overcome the resistance? All right. This is given by something called as the Ohm's law. We know we have learned about Ohm's law in high school, right? That is for electricity, which states that voltage is equal to resistance into uh, I, which is current, right? Okay, R into I, right? Similarly, there is Ohm's law for resistance here as well. Here, the pressure needed to overcome the resistance will be equal to resistance into flow. Okay, so if you need to increase the flow, suppose if I'm exercising, or if I'm really sick and I need a lot of air very quickly. Okay, suppose I'm in shock, I need to wash out my carbon dioxide in a quick way. For that, I will be hyperventilating, right? In such cases and all, you need to get more volume in more quickly. That means the flow has to increase because flow is just volume by time, right? Okay, so if you want to increase the flow, and if your resistance is constant, that means you will have to do more work to increase your pressure needed to overcome that resistance, right? So it's very simple. If the resistance is constant, to increase the flow, you need to increase the pressure needed to overcome the resistance. Okay. Now, another way of looking at it is just look at the flow here. That is pressure divided by resistance. Okay. What is more important for us is that a flow or a volume of gas reach into our alveoli over a certain amount of time. Okay, for gas exchange to happen, right? Now, in a lot of textbooks, they use different methods or different letters to actually represent the flow here. Sometimes they use F, sometimes they use Q, sometimes they use V with a dot on top of it. Okay, remember, this is not just volume, it's flow. Okay, V with a dot on top of that is going to be flow. Many students get confused when they see this thing. Okay, now if you remember something called as the Poiseuille's equation, see, Mr. Poiseuille, he said that flow is also can be represented by the formula of pi p r raised to 4 by 8 eta L. All right. See, I used to find it very tough during the high school time itself, but I'm telling you, see, now it all makes sense. All right. After learning about its importance in mechanical ventilation, it makes a lot of sense to me. Okay. So just remember this thing. Flow is equal to pi p r raised to 4 by 8 eta L. All right. Now, if I use this part here, okay, and substitute it with flow with my Ohm's law, I'm going to get something like this. All right. Okay. Here, we can find out what the resistance is. Now, the resistance is going to depend on eta, L, and R here. What is eta? Eta is the viscosity. What is importance here? See, as the fluid becomes more viscous, resistance increases. Now, if you remember, in asthma patients, one of the treatment that can be used is something called as a heliox treatment or heliox therapy. Because adding helium to oxygen reduces the viscosity there, right? So the resistance will be low, and during the bronchospastic state, you can get more air inside the alveoli. All right, it will increase the ventilation. It will improve the ventilation in the asthma patients. Okay, now what is L? It is the length of the airway. Okay, or there used to be a practice of cutting the ET tube to reduce the length, but nowadays we are not doing that. Okay, but the most important thing here is going to be the R in the denominator here, which is radius of the airway. Okay, now you see that it's raised to the power of 4. That means if the radius is reduced to half, the resistance is going to increase by 16 times. All right. Okay. So radius is the most important thing. So what are the conditions there where you can get a small radius in the airway? Bronchospasm, right? Asthma patients, COPD patients, anaphylactic patients, they can all have bronchospasm, right? Which will decrease the radius of the airway and increase the resistance. Of course, as the resistance increases, the pressure required to overcome the resistance has also increased, right? That means our inspiratory muscles have to do more work. So this is why these patients are having increased work of breathing, which is evident by use of the accessory muscles. The intercostal muscles, intercostal retractions will be there. Neck muscles will be used. So in neck muscles, you can be seen as straining. The patient will be diaphoretic. Nasal flaring could be there. So all these things are because of a decrease in the radius of the airway. All right. Now, suppose if the patient is intubated, okay, if you are using a very small tube, instead of using a larger size tube, if you are using a very small tube, again, you are reducing the resistance of the air. Sorry, again, you are reducing the radius of the airway, right? Because after intubation, even the ET tube as well as the ventilator circuit is part of your airway, is part of the patient's airway, right? Okay. So let's see what are the different conditions you can get high P resistance. All right. Suppose if the alarm is going off for high pressure in the high peak inspiratory pressure in your ventilator or the patient, then you need to look for these conditions. Okay. More bronchospasm, I already mentioned. Small ET tube, I have already mentioned. Other things are fixed airway obstruction, like there is a tumor in the airway or there is a foreign body in the airway. Then mucus plugging. It can happen in intubated patients. Okay, either inside the ET tube or inside one of the smaller airways in the lungs. All right. Then tube blocks, kinking of the tube, ET tube, then secretions in the ET tube. Those things are also very important. Okay. Now, in the ventilator circuit, it can be secretions in the ventilator circuit. That's why some of the ventilators, they have something called as a water trap to trap all the secretions in there, even the humidification. Then kinks in the ventilator circuit. Okay, you need to consider all these things. All right. Okay. Now, what about the pressure needed to overcome the elastance? Okay. Again, sorry for doing this to you. There is a formula for calculating this. All right. Pressure needed to overcome the elastance equal to elastance into tidal volume. All right. Why instead of flow, we are taking tidal volume here? Because the tidal volume is what is going to actually distend the alveoli, right? It is the part or it is the volume which has to overcome the elastance of the alveoli, right? Okay. Now, elastance, I already mentioned that it is the um, what it is the property of a substance which prevents change in its volume, right? See, but what do we actually want? We want to distend the alveoli so that gas exchange will happen. So instead of elastance, it's exactly the opposite of elastance, which is much more of a concern for us, right? So the opposite of elastance is called as compliance. Or compliance is the distensibility or the ease with which we can distend an alveoli when you give a tidal volume. All right. So we can rearrange the formula again. So to find that compliance is equal to tidal volume divided by pressure needed to overcome the elastance. Okay. Suppose I want to have a higher tidal volume and the compliance is normal. It's in the stable state. That means I have to increase the P elastance. All right. Now, obviously, if the compliance decreases and you need to get the same tidal volume, you need to do again increase the P elastance. All right, I hope that's clear, right? So whenever there are conditions which decrease compliance, so what are the conditions which can decrease your compliance? All right, it's usually the parenchymal diseases like pneumonia, ARDS, pulmonary edema. Then you can have conditions which actually prevent the alveoli from expanding, like a pneumothorax, which is sort of like a restrictive pathology there. There can be interstitial lung diseases, lung fibrosis. There can be chest burns, chest wall burns, okay, which decreases the chest wall compliance and prevents the alveoli from reaching the or prevent the lungs from reaching its inspiratory capacity. All right. So all these conditions can reduce your compliance. All right. So which will require a higher pressure to overcome the increased elastance here. Remember, compliance, which is the opposite of elastance. Whenever there is low compliance, it means elastance has increased and the pressure needed to overcome that elastance has to increase to get the same tidal volume for us to breathe. Right? Clear? Now, what is normal value of compliance is 70 ml per centimeter water. Okay. Where did that unit come from? Compliance is going to be VT by PE, right? Tidal volume by pressure. So tidal volume, I have already mentioned, we are mentioning it in milliliters and pressure in centimeter water. All right. So that's how all these units are coming. All right. Okay. You will get familiar with this as you see more patients. Okay. Next time, just look at these units. Okay. I have already gone through this. Now, one more important thing is high tidal volume. It can also reduce your compliance. How does it do that? Again, remember the balloon. All right. See, whenever you inflate the balloon, in the middle part of inflation, the balloon expands very easily. Right. Now, as you reach the limit, the balloon becomes very large. Right. As you reach the limit, then it becomes really, really hard to blow in further air inside the balloon, right? Because that's a property of the elastic substances. All right. So whenever you give a lot of high tidal volume, at the end, whenever the capacity is reached, the compliance will again start coming down. Okay. If you are taking just normal tidal volume, the compliance will remain stable. But towards both ends, the compliance is going to be much, much lesser. Okay. Chest wall deformity, again, like kyphoscoliosis, that can also restrict the chest wall movements there. Okay. Now, coming to the work of breathing thing, again, equation of motion again, we can write the P muscle as the total pressure required to overcome equal to P resistance plus P elastance. Now, instead of PR and PE, we are going to put in this formula in. Okay, so P mus is equal to resistance into flow plus volume by compliance. Okay, so whenever there is an increase in the resistance, or whenever there is a decrease in the compliance, in order to maintain the same flow and get the same volume, of course, your P mus has to increase. All right. So more work has to be done by the inspiratory muscles. I hope this part has been clear. Okay. Now, that's about inspiration. Now, how do we breathe out? How do we expire? Expiration is also important, right? Okay. Inspiration, we are taking in oxygen, but expiration is very important because we need to breathe out carbon dioxide. All right. Now, inspiration, all the inspiratory muscles have to work, right? Mainly the diaphragm and the parasternal intercostals. Now, expiration, it doesn't require any muscles. Okay. So it is a passive process, whereas inspiration was an active process. Okay. What expiration requires is just relaxation of these inspiratory muscles. So the diaphragm from its flattened state goes back into the dome-shaped position. Okay. The parasternal muscles relaxes. All right. Okay. What it does is it brings the thoracic volume back to its relaxed state. All right. But there is already the tidal volume inside the lungs. Okay. So this relaxation or the reduction in the volume of the thoracic cavity actually pushes the volume, the tidal volume inside the lungs, so that the pressure inside the lungs now increases more than the atmospheric pressure. Again, a pressure gradient is created and we breathe out. It's as simple as that. All right. Just like that. Okay. Now, of course, all you need to do is, again, during expiration as well as there will be resistance you need to overcome in the airway. And that resistance will be overcome by the elastic recoil of the chest wall as well as the lung. Okay. So whenever the inspiratory muscles relax, the elastic recoil of the lung as well as the chest wall will result in the expiration. Done? All right. Now let's move on to ventilatory support. Okay, so that was a tough part, all right, in respiratory mechanics, or the physics in breathing, or the physics in the biology of breathing, or the physiology. All right, okay. Now let's move on to the ventilatory support part. Okay. Now let's take a look at this patient. This was one of the patients who I had treated during the COVID time, all right, in the early stages of COVID. Okay. Now this is a CT thorax, all right, and it's a cross section of the thoracic cavity. You can see there is some ground glassing here, which is suggestive of COVID pneumonia. Okay, which is suggestive of pneumonia. The patient was having COVID, so it's COVID pneumonia, right? Okay. Now, after 7 days, we repeated the CT for the patient, and this was what we were seeing. Okay, and this is what you can see. See, the normal black areas in the initial CT is because the black is represented by air there. So that those are the alveoli involved in gas exchange. But you see, after 7 days, when we repeated the CT, the posterior part of the lungs are almost entirely collapsed. All right? There is all lot of pooling of secretions there, exudates are there. The alveoli have collapsed. It's called atelectasis happening there. Only a few part of the lung is black here, which is representing gas exchanging alveoli there. Okay. Now, usually in our oxygenation strategy, we will increase the FiO2, right? By giving more and more oxygen, right? But what if the alveoli is completely collapsed like this? Is there any point of increasing the FiO2 further or increasing or giving more and more oxygen? Is it going to improve your oxygen saturation? The answer is no, because all the alveoli collapsed here. Whatever air you are giving is not reaching this alveoli for gas exchange. So whatever increased oxygen you give, it's not going to improve the saturation. Okay. Now, the reason for this alveolar collapse is because most of these conditions like pneumonia or pulmonary edema or even ARDS reduces something called as surfactant inside your alveoli. Okay, the surfactant is one of the chemicals which is involved in preventing the alveoli from collapsing. So when is the highest risk of alveolar collapse? Okay, when is the highest risk for alveolar collapse? It is usually at the end of expiration when you are expiring out more and more air outside. Okay, there is minimal air inside the alveoli, which is your functional residual capacity, right? But the surfactant prevents the alveoli from collapsing here. All right. So in all these conditions, in pathological conditions, the surfactant production is reduced because type 2 respiratory cells are destroyed here, right? So the alveoli is going to be like this without surfactant. Okay. Normally, when there was surfactant, the inspiration and expiration was happening from this stage to this stage. All right. From stage 3 to through 1 and through 2 here. All right. Those were the steps there. Okay. Now, if the alveoli is completely collapsed, first the patient must do enough work to inflate the alveoli to its normal state. Okay. Now he has to do extra work for getting the tidal volume. All right. So this extra work has to be done by our inspiratory muscles. So the work of breathing increases. So that's why these patients again have increased work of breathing and respiratory distress. Okay. Now, what can you do here? All right. What you can do here is you can either do something called as a continuous positive airway pressure. All right. Or you can call it even as PEEP, positive end expiratory pressure then. That means even at the end of expiration, you are keeping a pressure inside the alveoli so that the alveoli do not collapse at the end of expiration. Okay. And you are increasing the pressure, the baseline pressure inside your airways as well as the alveoli so that whatever alveoli that has collapsed kind of opens up. This is called as recruitment. Okay. You are giving positive pressure to recruit the collapsed alveoli. And you are using positive pressure to reduce the collapse of these alveoli. Okay. Now, if you are using this NIV machine for that, we call it as continuous positive airway pressure. This can also be given by something called as HFNC. All right. We do not use the term of CPAP, but HFNC, as the flow increases, you can give some kind of pressure support, which will also help to prevent the alveoli from collapsing. Okay. Now, if you look at it in a diagrammatic way, you can see that this is going to be your inspiration during normal breathing, and it's going to touch the baseline at the end of expiration. That is going to be, the pressure is going to be 0, same as atmospheric pressure, right? And you can see inspiration, expiration happening here. Now, when you apply CPAP in a normal patient, what you can see is that the baseline pressure is going to be elevated, right? So instead of 0, even at the end of expiration, there is going to be a higher pressure there, a positive pressure there. Okay. This is what responsible for preventing the alveoli from collapsing or recruiting the alveoli, right? This is called as CPAP, continuous positive airway pressure. It is one of the modes in NIV. All right. Now, what if the patient comes to you in severe distress? Okay, the work of breathing is too much. See, all these inspiratory muscles, including the diaphragm, they are skeletal muscles, right? They can undergo fatigue. Okay, and once fatigued, they can't do further work anymore. All right. And these patients won't be able to produce adequate gas exchange. So carbon dioxide starts building up in their body. Okay, it will result in respiratory acidosis. All right. And at a stage, they might even stop completely working. These muscles can get completely fatigued, and the patient may go into respiratory arrest followed by cardiac arrest. Okay. So initially, there could be just oxygenation problem there. But as the respiratory muscles tire out, there could be ventilatory problem as well. Ventilation here, I just mean the gas exchange happening, air movement happening. All right. So after that, the patient might go into respiratory arrest and finally into cardiac arrest. Okay. Now here, CPAP is not enough, right? You need to have ventilatory support as well. CPAP was there just to increase the oxygenation. Those methods are not enough here. Even though it reduces some of the work of breathing, it doesn't provide much of ventilatory support. Okay. So for that, for example, see this patient. This is one of the patients who came to me with severe pulmonary edema, and he was having severe respiratory distress. You can see that the patient is really you can see he's using his accessory muscles for breathing, and he's on an NIV. Right. Okay. So whenever your muscles, inspiratory muscles, are not able to meet the ventilatory demand, we call that as ventilatory failure. Okay. To represent that in a mathematical way, P muscle is not able to meet the ventilatory demand. Ventilatory demand is going to be PR plus PE, right? Okay. Now, another way to represent is that P muscle is less than resistance into flow plus volume by compliance. All right. So there could be many reasons for this. Okay. It could be a primarily ventilatory supply mismatch. Okay. There is going to be a ventilatory supply, ventilatory demand mismatch. All right. Whenever there is increase in resistance, or whenever there is increase in PR, or whenever there is increase in PE, we will say that the ventilatory demand has increased. All right. Whether the ventilatory muscles, inspiratory muscles are able to meet that demand. All right. So that is going to be ventilatory supply, which the inspiratory muscles can do. If it can meet the demand, it's fine. But if it's not able to meet the demand, then it's going to be ventilatory failure. Or if the even if the ventilatory demand is normal, if there is something problem with the ventilator supply, all right. For example, there is respiratory depression due to neuronal problems like head injury or due to toxins, or there is neuromuscular diseases like myasthenia gravis or polio, or even some toxins, snake bite, neurogenic toxins. All these can reduce your ventilatory supply, right? Again, there is a mismatch. All right. So this is called as ventilatory failure. Okay. This is just what I mentioned. Whenever the ventilatory supply decreases or when the ventilatory demand increases, there is a mismatch, and this is called ventilatory failure. Okay. Now, I already mentioned this. It could be because of a respiratory center problem, a neuronal problem, neuromuscular problem, or it could be a muscular problem, right? Now, it could be because of increased ventilator demand from high P resistance or because of low compliance and high P elastance. All right. Okay. These things we have already discussed. Right. Let's move on. Okay. Now, the ventilatory support. See, this patient, the patient which I just showed, this patient was in respiratory arrest. He was still breathing, but his work of breathing was very high. I just needed to support his PMUS or his inspiratory muscles. All right. Then it is called as a partial ventilatory support. Okay. So here the equation becomes P muscle plus P vent. Okay. The pressure provided by the ventilator will meet the ventilatory demand, which is PR plus P. Okay. This is something called as partial ventilatory support. Now, what if you are intubating the patient or paralyzing the patient, or the patient comes to you in respiratory arrest? Then there is no P muscle there, right? The patients on inspiratory muscles are not providing any kind of pressure support there. Okay. Then you need to provide complete ventilatory support. All right. Okay. So when you provide complete ventilatory support, there is no PMUS there. All the pressure has to be generated by the ventilator itself. All right. Okay. So P vent, it will become equal to PR plus PE. Okay. Now that brings us to the topic of types of ventilators. All right. So initially, the ventilators try to mimic the normal negative pressure ventilation. Okay, so there was negative pressure ventilators, but these were huge machines called as iron lungs, and the patient was fully inserted inside that. Only the patient's head was outside. All right, there was no access to the patient's body, even the limbs in these kind of ventilators. So how negative pressure ventilators worked was that it created a vacuum inside, a strong negative pressure inside, which expanded or pulled out the thoracic cavity, and that negative pressure was transmitted to the alveoli, and the patient could breathe in. Okay. Now, patient could expand by the release of this negative pressure and the elastic recoil of these structures. All right. Expiration is going to be the same way. It's passive, right? Now, the problem was that when the polio epidemic or the polio pandemic hit the United States, this was the state there. All right. There wasn't enough negative pressure ventilators available. And the sad part was that the polio mainly affected children. And there was a stage when even ventilators had to be shared by these kids. All right. See, this led to the discovery. Even before that, there was positive pressure ventilators. But this was a crucial time when they had to use these positive pressure ventilators, and they manufactured a lot of these ventilators. Okay. So what positive pressure ventilator does is that instead of creating a negative pressure outside, which was, and we were pulling in air, positive pressure ventilators actually creates positive pressure outside and pushes in air. Okay, it's the exact opposite of normal physiology. That was a problem with positive pressure ventilators. Whenever you mess with the physiology, there are going to be consequences, right? But these machines are very small and very light, so you didn't require a huge space and a lot of resources to manage patients on negative pressure ventilators. Okay. Now, this is one of the positive pressure ventilators. If the patient is able to maintain the airway, if the patient is able to protect the airway as well, then most of these patients requiring ventilatory support can be done with non-invasive ventilators. All right. If they are having good effort as well, non-invasive ventilators are a good choice, because intubation and invasive mechanical ventilation is associated with a lot of side effects, can be associated with a lot of side effects. Okay, it's very resource intensive. All right. The patient will have to be given a lot of sedation, and patient ventilator dysynchrony can happen. Tube related complications can happen. Barotrauma is more likely, as well as you require a lot of resources to take care of these patients. Okay. Because now they have become completely dependent when you intubate the patient and put him on a ventilator. All right. So NIV would be the first choice if the patient is able to maintain the airway. Just remember that. All right. And in NIV itself, another mode. See, we have discussed one mode of CPAP, right? But it doesn't provide much of ventilatory support as well. In order to provide ventilatory support, you need to choose another mode called as BiPAP, or bilevel positive airway pressure. Okay. I'm sure all of you have heard about these terms. Otherwise, whenever you get into practice, whenever you start your residency, I'm sure that NIV is one of the commonest equipments which you will be using in your practice. All right. Now, how NIV works or how BiPAP works is somewhat different from a CPAP. Okay. In CPAP, what we are doing is that the machine was giving a continuous positive pressure. The same pressure was given during inspiration as well as expiration. All right. That was something called as a baseline pressure. The baseline pressure was elevated from 0 to a positive level. Okay. Now, what BiPAP does is that you are doing or you are keeping two separate pressures. One is going to be an elevated basal pressure, which is there during expiration, which is same as the CPAP, right? That is called as the expiratory positive airway pressure. Now, during inspiration, you are going to give a higher pressure. All right. So in NIV machine, whenever you choose the BiPAP mode, the machine will ask you to set two pressures. One is called as an IPAP and the other is called as an EPAP. So IPAP is inspiratory positive airway pressure. So that will be a higher pressure during inspiration. You are supposed to keep it more than the expiratory pressure. And expiratory pressure or EPAP is going to be your same as the CPAP. Okay. So EPAP will help to improve your oxygenation by opening up the collapsed alveoli. And the difference between IPAP and EPAP, see what you have just done is, again, you created a pressure gradient or a pressure difference, a higher pressure during inspiration and lower pressure during expiration, a pressure gradient. Of course, you know the principle. Whenever there is a pressure gradient, air will flow from higher pressure to lower pressure. So this patient will get an extra volume of air. See how the BiPAP machine or NIV machine is giving this pressure is actually by the flow of air. Okay. If you just connect this mask to the patients, or suppose you connect it to yourself, you can see that there will be a huge flow of air, continuous flow of air. Okay. And this pressure is generated by this continuous flow of air. All right. So if you draw the graph, what you're seeing is that in a normal person, if you apply BiPAP, the inspiratory pressure will be like this, and the expiratory pressure will be same as your CPAP here. Okay. The patient will be breathing at a higher pressure here. All right. But this is not the reality in patients in ventilatory failure. Okay. Now, I have mentioned this is in a normal patient, right? But what's happening in ventilatory failure is that this patient is not able to breathe normally. Okay. He's not able to generate the normal pressure. So the inspiratory pressure will be somewhat lower here in these patients, right? This is not on NIV. This patient is not on NIV before that. Okay. Now, even if you give CPAP, sorry, yeah, even if you give CPAP, again, the inspiratory pressure is not going to be that high. So the tidal volume will be much less. So what we are trying to give or what we are trying to achieve by giving two pressures is by increasing the tidal volume to at least this level here. All right. Or if the patient has a much more ventilatory demand, a bit more higher. All right, I hope that's clear. At least learn this, you need to set two pressures. BiPAP is a mode which provides ventilatory support. So it's better that all patients with respiratory distress start them on BiPAP itself. All right, so that you can reduce the work of breathing. Okay. Now see this patient. Okay, this is again is a COVID patient. Now he's on BiPAP. But even on BiPAP, you can see he's having respiratory distress. All right. His respiratory effort is really poor. He's kind of having paradoxical breathing as well. And you can see he's trying to remove the pulse oximeter and trying to take off the mask as well. We are trying to help him, but the patient is trying to take off the mask, which tells you that the patient is not tolerating the machine and he's kind of disoriented. Okay. And he's going into fatigue. Even a patient on NIV can have respiratory distress and can go into respiratory fatigue. Okay. Now take a look at this patient. Ah, yes. This is your gasping patient, right? Okay. So is there any point of starting NIV in this patient? You can see the vacant staring of the patient, his respiratory efforts are poor. So in these kind of patients, see, this was a terminally malignant patient. That's why we were not doing anything for this patient. All right. But this is one of the things which you can learn. Suppose if this patient wasn't having a terminal malignancy and he was brought to your emergency department in this stage, you would go ahead and intubate this patient and provide mechanical ventilation. All right. So these are the indications for intubation. Poor respiratory effort, patient is not able to maintain the airway or protect the airway, you need to intubate these patients and give invasive mechanical ventilation. All right. Now, mechanical ventilation can seem like a puzzle to you. I'll try to make it simple. Okay. Now, again, I already mentioned that the P vent is going to be equal to PR plus P elastance. Okay. Here, the ventilator, what it does is it creates a positive pressure outside the airway, and this will create a pressure difference. Instead of the negative pressure gradient we are creating, here a positive pressure gradient is created. Okay. So ventilator is a machine. It's just a machine. All right. Which creates a supraatmospheric pressure outside the body so that a volume of air flows into the lungs or the alveoli over a period of time. That's how you define mechanical ventilation. It's as simple as that. All right. Now, ICU ventilators, they can be basically divided in pneumatic ventilator, compressor ventilator, turbine ventilators. I'm not going to go into the details of that. You can find all those things in the app. I will be showing all these kind of ventilators in the app, Residency app. Okay. Just remember these things. There are the parts of the ICU ventilator. It has an electronic part, which is sort of like the computer, which has all the softwares, which controls the hardware part. Okay. So this is the hardware part here. The hardware part mainly contains a lot of valves, a lot of sensors, resistors, which helps to measure all the flows, all the pressures. Okay. Now, there are flow sensors and pressure sensors, which helps to measure the flow as well as the pressure. The volume is calculated by measuring the flow. All right. Now, whenever we are connecting a patient to the ventilator, see, I already told you that whenever we increase the pressure, the volume increases. More PMUS means more volume comes, right? Okay. So you have seen that pressure and volume are sort of connected, right? So whenever we put the patient on the ventilator, I can control only either pressure or the volume. Okay. Now in ventilator, we are controlling the volume by controlling the flow. All right. Because flow is almost same as the volume, only the time part is there, which differentiate them. Flow into time will give you the volume, right? It's volume control ventilation or pressure or flow control ventilation. Both are the same thing. All right. Then we have pressure control ventilation. Okay. So what is this thing is that, see, either I can tell the ventilator that I want the ventilator to deliver this much volume. Suppose I want the ventilator to give the patient 400 ml of tidal volume. The ventilator, let's say it takes around 5 centimeter or let's say 10 centimeter water of pressure was generated by the machine to deliver 400 ml of tidal volume, right? Now I'm telling the ventilator to deliver 500 ml of tidal volume. Okay, so the pressure, the machine will generate a higher pressure. Maybe it would be around 15 centimeter water, right? To deliver this higher volume. See, what am I controlling here? I am controlling the volume here, all right? But I'm not controlling the pressure. The pressure is being generated by the machine to deliver this much volume. Okay, so whatever, if I'm controlling the volume, it's called as volume controlled ventilation or volume targeted ventilation. But I'm not able to control the pressure here. Okay, suppose if I'm giving 500 ml of tidal volume and the pressure goes to around 40 centimeter water, this is going to be dangerous because anything more than 30 centimeter water pressure can result in barotrauma. Okay, so I want the ventilator to reduce the pressure. I want to control the pressure here to prevent barotrauma. So I'm telling the ventilator or I'm setting on the ventilator that whatever happens, you give only 20 centimeter water pressure or even 30 centimeter water pressure. Okay, now ventilator generates only that much pressure. Suppose if there is an airway resistance problem or a compliance problem, the tidal volume might be only on the 200 or 300 side. Okay. If that is not clear, let me make that even simpler. All right. Suppose I tell the ventilator to give only 10 centimeter water pressure. All right. I look at the ventilator and see that the patient is getting only 200 ml of tidal volume. We know that's not enough. Okay, every patient should get at least 6 ml per kg of tidal volume. This is not going to be enough, right? So what can I do? I will increase the pressure setting in the ventilator. I make it around 20. Okay. Now I'm seeing that the patient is getting around 500 ml of tidal volume. So what I am setting here or what I am controlling here is the pressure. Okay. What is not under my control is going to be the volume here. So this is called as pressure controlled ventilation. Okay. So in any ventilator, you can choose either volume control or pressure control, but never both at the same time. All right. Okay. And this is a basic concept only, right? Now let's move on to the modes of ventilation. And after that, we'll conclude the session. Okay, I'm just going to touch some of the conventional or the basic modes of ventilation. Okay, now what do you mean by a mode of ventilation, right? What is this? All right. Of course, it's not a ventilator. I know that. Okay, this is my washing machine actually. All right. I'm just trying to make that, tell you that, see, it's also a machine, just like the ventilator. What it does for me, it does the work of washing my clothes, right? Similarly, ventilator does the work of breathing for me. Okay, ventilator does the work of my inspiratory muscles. All right. Now, if you look at my washing machine here, you can see that if you have washing machine at your home, you can look at that as well. All right. Okay. You can see that there are a lot of settings here. Okay. And there are a lot of modes here. All right. For sportswear, there is one mode. There is some mode called as baby care. Cotton clothes, there is another mode. Synthetic clothes, there is another mode. Then heavy clothes, there is another mode. All right. See, whenever I select one of these modes, what's going to happen is that these settings are going to be changed. Okay, so these settings will be predetermined on how to wash my clothes. All right, so the temperature will change, the rinse time will change, the spin time will change, and I don't know what the last thing is there. All right, but all these preset parameters will get changed. Okay, whenever I change the mode. The same thing happens in ventilator. When I change the mode in the ventilator, the way a breath is delivered to the patient also will get changed. All right. So how I want the breath to be delivered to the patient is determined by the mode which I choose on the ventilator. All right. So ventilators have a lot of different modes, and usually this is one of the ventilators which is commonly available by MACA. I don't have any commitment to these kind of instruments. All right. But how do you select the mode? There is one button here. Most of the ventilators now have a touch screen. Okay. There is one button here which is called same as volume control. Now, if you just press on that button, you are going to get a screen with all the ventilator mode options there. All right. Just like in my washing machine there, you can see all the ventilator modes here. Okay. Now, if you select any one of those modes, you are going to get other parameters, other detailed parameters in each of the breath, which is being delivered by the machine here. Okay. Similar to the settings in the washing machine there. All right. I was just trying to make it simple. Okay. This is how I learn. All right. Okay. Now, one of the commonest modes which you can choose is something called as a volume control mode. All right. Okay. This is the definition again, which I already mentioned. It is the settings which determine how breaths are delivered to the patient by the ventilator. And in turn, this determines how much work of breathing is done by the ventilator for the patient. All right. Okay. Basically, we are going to discuss only about flow controlled ventilation in our this in this section, all right, because this is the commonest mode that we are using for flow or volume control ventilation. All right. Now, if you look at the ventilators, there are a lot of modes, and newer modes are being added on. But these are the conventional modes available in most of the ventilators. And out of these, okay, you need to know only basically two modes: ACME mode and pressure support and CPAP mode. Okay, or the PSV mode. All right, remember two modes: ACMV, and PSV or pressure support bar CPAP mode. Most of the ventilators, these kind of mod names are kind of branded. All right. So you might find different names for these kind of ventilators. All right. Okay. Now, what ACMV mod means is that, okay, again, the kind of breaths I already mentioned, choosing the mode will change the kind of breath that is given by the ventilator, right? So, in whenever there is a patient is put on a ventilator, you can have four kinds of breaths. All right, either a mandatory breath or sometimes called as a controlled breath. You could have an assisted breath, then something called as a supported breath, and then there is finally the spontaneous breath. Now, how these breaths differ is by knowing who controls which parameter in breathing. For that, we can divide the breathing into four phases. One is the trigger, then the inspiration part, then cycling, and finally the expiration part. Let's leave the expiration part because it's passive. All right. Ventilator can also only give the breath. It cannot help the patient to expire. Okay. Expiration is still a passive process caused by the elastic recoil of the lung. All right. Now, what do you mean by trigger? Trigger is the setting or the variable which tells the ventilator when to deliver a breath to the patient. Okay. Now, this trigger can be done by the machine. That means we can set the trigger there, or the patient can trigger the ventilator. Okay. If we are setting the trigger, it's usually by setting the rate, the respiratory rate. See, suppose I set the respiratory rate as 15 breaths per minute. Every 4 seconds, one breath will be delivered by the machine. So what is the trigger there? It's going to be the time. Every 4 seconds, one breath will be delivered, right? Now, if the patient is in a spontaneous breathing mode or in a supported breaths or in assisted breathing mode, the patient can trigger the ventilator to give it a breath, to give the patient a breath. All right, just keep that in mind. Then what do you mean by cycling? Cycling is the change in phase from inspiration to expiration. Because every breath has inspiration as well as expiration, you need to allow some time for expiration as well. Usually, expiration takes double the time of inspiration, right? Because expiration is a passive process again. Okay. Now, in mandatory breaths or assisted breaths, almost all the work is being done by the ventilator. Okay, this is just like carrying the patient through that inspiration, okay, or throughout that breath. All right, fully the work is being done by the machine. Now, in supported breaths, what you are doing is you are just supporting the patient, right? It's like a helping hand there. The patient can trigger his own breath. The patient can cycle on his own. He can determine when to take the breath, and he can determine when to stop inspiration and expire. All right, but you are providing a pressure support there. And in spontaneous breaths, what happens is that the machine is not providing any support there. Okay. These are patients usually having head injury. You intubate the patient for protecting the airway and connect to the ventilator. The patient may not have any respiratory problem as well. All right. Okay. So let's see something about ACMV as well as pressure support ventilation here. All right. So in ACMV, if you choose that mode, you are going to find these kind of settings, which you need to set. Okay. So these are the basic settings which you need to start the patient when you're putting the patient on a ventilator. Okay. So you usually during intubation, we will sedate and paralyze the patient. All right. And you need the ventilator to provide complete ventilatory support to the patient. So that's when you choose the ACMV mode. Almost all the work of breathing will be done by the machine when you choose the ACMV mode. So of course, you need to set everything in the machine. See, it's a machine. You need to tell the machine everything on what to do, right? Okay. So in volume control ventilation, of course, you need to set the tidal volume. What is the usual tidal volume that you set? Usually, we are going for lung protective ventilation strategies. All right, we'll discuss all those things in there. Okay, so in that, the minimal volume that you give is around 6 ml per kg. 6 to 8 is okay. You can start with even 7 ml per kg, okay, of ideal body weight. Leave that, okay, just check what is ideal body weight. All right. Now, what about the respiratory rate? Okay, just not one breath is enough. You need to give multiple breaths because minute ventilation is more important, right? Okay. So respiratory rate, usually you start between 15 to 20. Now, if the patient is in respiratory acidosis and the patient is the patient has some metabolic acidosis and a lot of respiratory alkalosis is required, hyperventilation with a higher respiratory rate might be required. Anyway, starting at around 18 to 20 is a good. All right. Now, you can adjust the respiratory rate always by looking at the blood gases. Okay. Now, when you set the respiratory rate, suppose I already mentioned if the rate has been set as 20, okay? So every 3 seconds, one breath will be delivered, right? Now, this 3 seconds should include both inspiration as well as expiration, right? So in the machine, you have this option of setting something called as the IE ratio, inspiration to expiration ratio. Usually we start it as 1:2 because expiration requires usually the double amount of time. All right. But in some ventilators, you have the option of setting only the time for inspiration. Okay. So if you are having 3 seconds for a breath, you set it as 1 second for inspiration. So obviously the rest of the 2 seconds will be used for expiration. Okay. So now you have taken care of the breathing part. Now about the content of the breath, about the oxygenation part. Okay. The ventilation part has been taken care of, how to give the breath to the patient. Now, how much oxygen you should give? The baseline, the minimum you can give is 21%, which is same as room air. And the maximum is going to be 100%. Usually you start with 100% and titrate it down to the minimal FiO2 that is required to maintain saturation around 94%. All right. Now, how much PEEP should you keep? Okay. Now, what is PEEP? Now, PEEP is same as your CPAP. PEEP is positive end expiratory pressure. It also helps to prevent the alveoli from collapsing and also recruit the alveoli which have been already collapsed. All right. So minimal PEEP to start with is 5 centimeter water. All right. And do not worry about the trigger flow usually. Okay. Don't mess with the trigger flow if it has already been manufactured, recommended. Okay. So this is what I have already mentioned. T inspiration time, it should be at least 0.75 seconds to 1 second. Okay. PEEP. Okay. So what's the effect of PEEP? How does it work? So this is just an experiment on a frog lung. All right. So what this is showing is that at the end of expiration, the frog lung is completely collapsed. All right. Now the patient is going to
You're recording again with
yeah,
a different angle.
inflating it with air.
Don't shot, zip.
You can see at the end of expiration,
50.
the alveoli is completely collapsing. Now they are going to apply PEEP there. Okay, now you can see the alveoli is not completely collapsing. The lung is not completely collapsing. And you can see more and more parts of lungs are getting recruited. So this is called as recruitment maneuver. They have serially increased the PEEP here. Now they are going to turn off the PEEP again to back to 0. You can see what happens. All right. The lung completely collapse. So this is the effect of PEEP. So PEEP is something very important, right? Especially in ARDS patients. All right. Now let's move on. Now, what about pressure support ventilation? Okay. Now in pressure support ventilation, it is a spontaneous breathing mode. The patient triggers the ventilator as well as cycles the ventilator. All right. In this, you cannot set the tidal volume, you cannot set the respiratory rate because everything will be determined by the patient. But you can provide some pressure support, okay, to reduce the work of breathing. All right. So what you can set is something called as pressure support above PEEP. Now, if you remember, the pressure support above PEEP plus PEEP will be the same as the IPAP in NIV or in your BiPAP machine. Okay, so the pressure support above PEEP is going to be the pressure gradient, which determines the increase in the tidal volume. Okay, So if you want to increase the tidal volume the patient is getting, you need to increase the pressure support above P. But you cannot fix the tidal volume. Okay. Now, of course, FiO2 and PEEP can be set here. All right. Now, another thing you need to set when you're selecting a patient on pressure supported ventilation is something called as backup ventilation. This is very important. See, these patients are spontaneously breathing. What if the patient, for some reason, stops taking the breath? All right. The machine won't be able to deliver the breath here, right? Because there is no tidal volume, there is no respiratory, mandatory breaths have not been set here. But you need to set something called as the backup breaths here. All right. As soon as the patient becomes apneic, okay, the machine will spontaneously or automatically turn it into a mandatory breath mode. All right. So in that part, you need to set the tidal volume and respiratory rate. In case the patient goes into apnea, it will go into the ACMV mode there. Okay. So that's about ACMV as well as pressure supported mode. Now, this is my last slide. All right. Just remember this mnemonic of DOPT, D-O-P-E-D. Whenever you have a patient on ventilator who suddenly deteriorates, think about DOPT. D is for displacement of the ET tube. All right. So auscultate both sides whether there is equal air entry. Then you can have obstruction of the ET tube. All right. You are not getting bilateral air entry present. And when you are doing suctioning, there is some obstruction in the ET tube. Suspect obstruction of the ET tube. Do suctioning, and if it doesn't relieve the obstruction, you need to change the ET tube there. Okay. Then pneumothorax. All right. High pressure alarm goes, the saturation might fall down, or the patient's FiO2 requirement might increase. So auscultate again. Is there any decreased breath sounds on any side? You can use bedside ultrasound, point of care ultrasound to look for lung sliding. If it is absent on that side, look for the barcode sign. All right. If these are present, you need to suspect pneumothorax. So put a needle there to relieve the tension if it's present, or put a ICD there. All right. Now, every machine can freak upon you. All right. So always suspect equipment failure as well. The ventilator can malfunction. This happened. We saw a lot of this during the COVID pandemic. Okay. Now, finally, if nothing is there, if all of these are not there, what you can do is it could be because of the disease progression itself. The ARDS, the pneumonia patient has now gone into the ARDS phase. All right. Now, equipment failure, what can you do? How can you find it out? All right. Look for the alarms on the machine. Never disregard any of the alarms on the machine. Okay. Always pre-check the machine before starting any patient on mechanical ventilation. Make sure everything is functioning. Okay. If you are not seeing any of these things, disconnect the machine and ambu ventilate this patient. Okay. Connect the ET tube to an ambu bag and try ventilating the patient. If the patient's condition is improving, it could be because of equipment failure, right? It's very simple, right? So remember DOPED. All right. With that, I would like to take you to the take-home points. The ultimate goal of starting a patient on mechanical ventilation, your ultimate goal should be to wean the patient off the ventilator. Okay. This is just a time-buying procedure, right? Time-buying therapy. Now you can start the patient on ACME mode, and PSV mode is sort of kind of the weaning mode. From ACME, as soon as possible, move to PSV mode and wean the patient off the ventilator. Now the respiratory mechanics is very much dynamic. Any point of time, you can have an increase in the resistance or in the decrease in the lung compliance. Example, pneumothorax, right? The lung compliance can decrease because of a restrictive pathology there. All right. Okay. So to know more, this is just a beginning part of mechanical ventilation, right? If you want to know more about mechanical ventilation, you can always reach out to me, or you can go through the app, the Residency app. Okay. I'll be using a lot of simulation-based learning there, even on mechanical ventilation. All right. You can see all these alarms on the ventilator there. All right. So this is my Instagram profile, and you can reach out to me anytime, in my WhatsApp. That's my WhatsApp number as well. All right. So that's my message. Everything is obvious once you know the answer, right? So that's about the basics of mechanical ventilation. So for more on this, just try the Residency app. All right. Okay. We are working a lot in it, and I'm sure it will be worth it for you.